And I want to welcome everyone to the fourth Translational Teamwork Series. We have a wonderful group of people who are presenting today. And I'm just going to give a little overview of our workshop series in general, and then I'm going to turn it over to our wonderful group. We do have a lot of videos within the Core Competency Workshop series, workshops that we actually have presented through Zoom as we are doing today. And then we also have them recorded as you heard the recording. And what is really nice is that you have access to the video library. You just need to email me, Catherine Sedota, and I will give you access to the videos. And if you happen to have questions related to the videos, you can also either email the presenters, you can email me. I got a question today from last series, actually last Tuesday's workshop, and I just emailed that to the presenter so that she can clarify something for the person who watched the video. We do have a lot of core competency workshops within the series. Translational teamwork is just one. It includes things like Bird Bootcamp and mini-series. We have good clinical practice, effective teaching coming up actually in January. And then a lot of other ones too, including scientific communication and responsible conduct of research. The clinical and translational science skills are actually quite overlapping. There's strategic skills, hard skills, and soft skills. Team player is very important, and that tends to cross boundaries, as well as rigor and reproducibility. And all of these skills are something that you can learn as a result of watching some of these workshops. What you do need to know is this is just a snippet of the workshop. So what's really important is if you're looking for more concrete types of hands-on experiences, that's when you can start looking into possibly master's programs or classes you can take at UB related to some of what we're presenting today. So this is just supposed to be a taste of clinical and translational science. We have a very esteemed team today talking about the tools and strategies to enhance performance in clinical teams. And I will let them actually introduce themselves, but there's a lot of them on that are going to be teaching you quite a lot about these skills, and a lot of interactive work is what you're going to be doing today. What I want you to know is, could you please fill out the survey? Now, what I'm going to do is put the survey into the chat, and I'm going to send it to you through email 3 times. And it's really important. It's a very, very short survey, and it helps us to improve the workshop series and also to report out to our funding sources. I also want to tell you that if you are looking for help in a particular area, there's a CTSI service menu that you can also go to and you can search for within the web. And it is on our CTSI sites, and that can have you and allow you to ask questions, and someone will direct you to the specific area that you're looking for and connect you to someone who can help answer that question. And if you're not sure about which section it connects to, just click on not sure and you can ask your question there. So I'm going to stop sharing, and now I will allow Mr. Koza to share, and you can begin the workshop. Thank you so much.
Okay. And I'll turn it over to Dr. Gambacorda.
Thank you, James. Good afternoon, everyone, and thank you for taking some time to join us for tools and strategies to enhance performance in clinical teams. My name is Joseph Gambacorda. I'm a faculty member at the School of Dental Medicine. And I'm joined by James Koza, Kelly Foltz-Ramos, Lisa Jane Jacobson, and Ken Snyder, who will be talking about various aspects of some of the things we do as part of our interprofessional education office here at the University of Buffalo. But our mission is to prepare highly competent healthcare professionals who improve health outcomes by excelling in interprofessional communication, teamwork, and the provision of safe, ethical, patient, and population-centered care. Our goal really is to work with the students and let faculty know, too, who work with us. And we do have a lot of faculty across various disciplines that volunteer and do work with our interprofessional education office. And really, our goal is to prepare the students to go out into practice, especially with all the new healthcare delivery models that are out there, and how important collaborative practice really is to enhancing patient outcomes. And that's one of our big things as we look to prepare our students to treat the community in which they serve. So our goal is to create and implement experiential interprofessional education curriculum, including foundational immersion simulation and community-based service and clinical practice experiences to promote achievement of interprofessional education collaborative core competencies. These core competencies have been around and they're kind of on a national scale and things that we really use to kind of back up what we're actually trying to do. I know the academic health center deans are looking to expand the role of the assistant vice president for interprofessional education and really look to begin to create more aspects of interprofessional education and collaborative practice into the curriculums of each of the respective academic health center units. And I think this is really important, as I mentioned a little bit in going forward, how the landscape of delivering care has changed. This will really help prepare our students and, again, provide better care to our patients. And so here are some of the outcomes that we are looking at is work together in an atmosphere of mutual respect and shared values, understand the scope of practice of other health professionals and providers. And I can tell you, I've been around interprofessional education for a while, almost probably the second year as we really started doing things here at UB. And it's amazing how many students I have in dental medicine that come up to me after our forums in particular, but through some of the other things that we do, whether it's team steps or Friday night at the ER or any of our other events and learning experiences. And they can't believe how they can coordinate their care with other disciplines. So what I've been seeing and what the rest of the IPE leadership team has been seeing is getting that information back from surveys and how important these connections and students being exposed to these connections and collaboration is as they move on. Obviously, you want to develop effective communication skills to ensure high quality patient care. We want to perform effectively in different team roles. And it's plan, deliver, evaluate safe, effective patient-centered care. And it really developing a whole care plan that comprehensively helps the patient, also helps and works with the family of patients who may need our assistance as well. Obviously, we want to develop initiatives that promote interprofessional collaboration and scholarship, and provide opportunities for leadership and research in innovative IPE educational strategies and experiences. And we've had a lot of good experiences for our students that we've had a lot of positive feedback on. We've also have had pockets of clinical experiences where, for example, I've collaborated with the School of Nursing in taking nursing students and dental medicine students on rotations, whether we take them to a domestic location like, say, Knoxville, Tennessee, or Grundy, Virginia, or if we're working in refugee camps in Greece. We've really started to cement and get some of these projects going, which has been very well received by our students. So our leadership team is comprised of faculty from athletic training, audiology, counseling, psychology, dental medicine, dietetics, management, health sciences, medicine, nursing, OT, pharmacy, physical therapy. We also work with the PA program at Canisius College, public health, social work, and speech language pathology. And it's been my good fortune to work with many of these individuals over a long period of time, and the amount of dedicated service that they have given to the students has been an exceptional thing, and I'm honored to be part of it for such a long time. So next, I will turn it over to Dr. Jacobson.
Hi, everyone. My name is Lisa Jane Jacobson, and I'm coming to you from the School of Medicine. I'm going to talk just briefly about why we believe it's really important that in order to provide effective health care, we do it as a team. So I'm not sure how many of you all here, and if anybody feels like turning on their camera, we would love to see your faces. And we are actually going to have a breakout room in a little while too, so we're going to want you to definitely have your cameras on for that. But if I would love to, whether you want to raise your hand on the camera or put your hand up using, one of the emojis. How many of you have actually ever had to been part of a team providing healthcare? It might have been, you didn't have to necessarily have that specific role as a provider that you trained as a provider, but maybe working, as on the front desk or driving an ambulance at some point in your life or anything. Anybody ever had any clinical experience. How many? Okay, you got a couple. Yep, thank you. Okay, so and what we're going to talk about today, though, hopefully you won't even have to have been, you don't have to be a clinician in order to really understand what we're trying to talk about. You can be a patient, right? Or somebody with we're all in some way connected with the healthcare system as patients as well. This is an example here in the slide of a really effective team, right? As we, the pit crew, I don't watch a ton of car races, but when you do see a pit crew working, I'm always in amazement. In like 15 seconds, if not less, they've taken the tires off, they've put them back on, and the car's racing out onto the track again. And it's really an amazing thing to watch because it's a ballet. It is a incredibly structured experience where every single member of that team knows what to do. They know what their job is. They know what the people next to them are about to do. And they don't get in each other's way, and they do their job effectively and quickly. And that's what we strive for in healthcare. And we believe very strongly that we have to, not only the future of healthcare is to work even more as team members, but also to train our health profession students to do that as well. So this is kind of our example of the pit stop, right? And the pit crew, one of them. This is, potentially a code occurring in a emergency room or in a hospital bed, where every single member there of that team is working, knows what they're supposed to be doing, knows how it's supposed to run in order to, save somebody's life. There are other examples. I'm an OBGYN. So in the operating room, we deliver babies. Sometimes, if you think about that incredible team that's in that room, right? There's surgeons, there's an assistant, it might be a resident, it might be a PA, it might be a scrub tech. There's a scrub tech in the background on the left, and there's a circulator in the far background over there. On the other side of the table, you got an anesthesiologist. You might have a nurse anesthetist as well. You could have residents and other folks too on the other side of that screen. If you were delivering twins, and this is an example of a twin setup, you have a bunch of people there with 2 baby warmers. So you've got people from the NICU, neonatal intensive care unit, you got respiratory therapists, you got nurses. Everybody in that room has to know what they're doing and needs to work cooperatively together in order to effectively, have a good health outcome for our patient. Another example is, this is an outpatient example. So, again, as an OBGYN, the woman in the center is the focus of our care, a pregnant person. And, in the course of having an outpatient or a pregnancy, that person might see a physician, they might see a PA, they might see a nurse, they might see a nurse practitioner, they might see a dietitian or a counselor or a psychiatrist. We got the front desk person up there in the top left too, who's very important in helping to manage the patient's care and bringing them in and out and appointments and insurance and all the other parts that are also incredibly important in their care. And we got the dentist up at the top too. We want to make sure that women who are pregnant have getting their routine preventative dental care, but also emergencies occur. So we often have to call in and speak with the dentist about the things that we might need. Got a physical therapist there too. In pregnancy, that does quite a number on your back. And sometimes people need to actually end up, getting some physical therapy while they're pregnant. So there's quite a big team of health professionals that can be involved in one person's care. This is just another example of a long-term care facility. Maybe it's a rehab facility where somebody could have had an injury or a stroke. And, you can see there might be nurses, occupational therapists, physical therapists, all working together to, again, bring this person back to their regular functioning. So they can go home and function and do their regular activities of daily living. So we believe very strongly that interprofessional collaborative practice improves patient safety, outcomes, as well as patient satisfaction. Patients really like it when the team is working together. And they're knowledgeable about what each other is doing, and they're working, in a coordinated fashion. And it improves the person's health, the individual's health, but it also improves population health. We believe very strongly that it also strengthens the healthcare system as well. It also has been shown to reduce per capita healthcare costs. And as you know, we spend a tremendous amount of money on healthcare here in the United States, and it's gotten a little out of control. And when you work in a collaborative fashion where people, you're repeating tests over and over again, people, you're using the health workers in a wise fashion where we're all, again, coordinated together, it's less expensive. The care is less expensive. And another thing that's very valuable to know is that, this kind of collaborative practice has been shown to reduce provider burnout. And many of you have probably heard a lot about how a lot of healthcare providers have been experiencing more burnout than in the past. When you work in a team and you got somebody watching your back and you're working with a friend or somebody that you can, that you can communicate with and discuss your plans with, that often brings joy. People like community and they like working together. And, again, our goal is to be able to achieve the quadruple aim in healthcare. The goal is to have a great patient experience. So patients are happy. Of course, they're not happy with their illness, but they're happy with their care. That improve the quality of the patient's care as well as that of the population, so that health improves. Reducing cost is another important aim. And then making sure that the care team is also being cared for. And this improves, and improving their well-being is also extremely important. So would you take one moment to think about a time when you or maybe a family member or a friend was involved in a healthcare situation or a problem? You had a medical problem that you had to deal with. And if you can think for a moment, the number of healthcare professionals that had to be involved in that care, think about who was there. Did you need nurses and pharmacists and physical therapists, or who were they that you had to rely on in order to get the best care? And then was that care, coordinated? Did they seem to be working well together? Was the coordination of that care, important in the success of that person's recovery or your own recovery? I'd be curious to know if anybody would like to volunteer real quickly, an example of a healthcare situation they were in, or a loved one, where they thought that the coordination of the care on the team really played a big role. Anybody want to speak up and volunteer?
I'm happy to offer an example of where lack of coordination could have been a disaster.
We were going to get to that too, actually. So a lot of times people will think about, the negative side. Oh, my team wasn't very coordinated. And I actually want to ask you that in just about 30 seconds. Okay. But, sometimes people will say, well, my team knew what they were talking about. I didn't feel like people were telling me different things, different information, because they seemed to all be on the same page. They were communicating well. And the instructions were clear. And it was easy enough to go from one, provider to another to get the care I needed. Emily, did you want to say something or volunteer an example?
Just an example of good coordination of care. My father was just at the hospital yesterday for a procedure, and there was a lot of great communication. He ended up not having the procedure. He had to go to the ER. When we got to the ER, they were expecting him. And it was a very smooth transition from one section of the hospital to the next section of the hospital. And we were really just pleased with the way everything went and the way the team had communicated. Everybody in the ER communicated, and then he got his prescriptions, no problem. It just all flowed very well for him yesterday.
I'm so happy to hear that. And you know what? Things do go smoothly in many, many examples. We can all probably name ones where it doesn't. But it's that kind of scenario that we want to be able to replicate, and be able to strive for. And if you explain how important that is, and to our health profession students as well, that's what we want to teach them and educate them about. So let's go to what Michelle was just talking about for a second. I'd love you to, and it's going to be a good entree to Dr. Kelly Foltz-Ramos's portion that's coming up next. But could you do me a favor? And if you have the chat available, if you have it open, could you, without pressing return, so don't press return yet, put something in that chat that's just an example of something where you felt there was a problem with lack of coordination of the team wasn't working as well as it could have been, and why. That would be really helpful, because I'd love to see them, but don't press return yet. And our own folks can do the same if you want to. All right. I'd like to, if you don't mind, I'd like you to all press return now. Interesting. So I'm reading about during the birth process, maybe there was a miscommunication. The doctor was there, but somebody didn't know that, was giving misinformation. Different instructions. I had put that one in. So yeah, so boy, somebody not reading the memo, getting a good sign out and taking the vitals maybe when they weren't supposed to. Yep. Mistakes can occur. As we know, mistakes are a huge problem in the hospitals, and where we do so much to try to prevent them, but they do occur. Lack of good communication resulted in paperwork not being submitted correctly. Thank you for those examples. So I'm going to, with that, and we know that this is what our job is, to work on trying to combat these problems, right? And I'm going to turn it over to Kelly, to Dr. Foltz-Ramos to speak a little bit more.
Thank you. My name is Kelly Foltz-Ramos. I'm the Director of Simulation and an Assistant Professor with the School of Nursing. I'm a member of the UB IPE leadership team, and I was the co-creator of the UB IPE Team Steps program. So today, in talking about clinical teams, we are going to be delving into an essential framework known as Team Steps, which has significantly influenced and reshaped the landscape of healthcare teamwork and patient safety. So Team Steps stands for Team Strategies and Tools to Enhance Performance and Patient Safety. And just to give you a little bit about the roots of Team Steps, it was initially developed in 2003 as part of a collaboration from the Department of Defense and the Agency for Healthcare Research and Quality. This was a direct response to the 1999 Institute of Medicine report to Errors Human that said that medical errors related to miscommunication cause up to 98,000 deaths annually. So the goal of Team Steps, the primary goal, is to address the critical need for enhancing patient safety through improved teamwork and communication within healthcare settings. And Team Steps is a toolkit, essentially, that contains different strategies to improve how healthcare teams operate. So we're going to put a link into the chat now of a pocket guide, a Team Steps pocket guide that actually has every single Team Steps tool in it. So you will have access to those. We're only going to be focusing on a few of them today during this workshop, but you have access to the entire toolkit. So looking at the domains of Team Steps on the screen here, the key goals of Team Steps revolve around empowering teams to elevate their performance. So when we think of communication in Team Steps, it aims to improve communication skills among healthcare professionals, enabling clear and effective information exchange critical for patient care. So when we think back at all the pictures that Dr. Jacobson had up and how essential it really was in those different situations for clear communication to keep the patient safe, Team Steps has tools to ensure that there's clear communication. Situational awareness, this is where Team Steps helps teams increase their awareness of their environment, ensuring a better understanding of patient needs and potential risks. And we know that situations are always changing, so knowing that our priorities are shifting and that we're always keeping an eye on those changes. Mutual support. By promoting a culture of mutual support, Team Steps encourages team members to assist one another, enhancing the overall team effectiveness. And lastly, leadership focuses on enhancing leadership abilities within teams ensuring that individuals can effectively guide and coordinate efforts for optimal patient outcomes. So before we talk about the different components and strategies of Team Steps, I want to tell you about Team Steps at UB. So at UB, the Interprofessional Team Steps initiative was implemented involving students from medicine, nursing, pharmacy, physical therapy, occupational therapy, dietetics, and physician assistant students from Canisius University. The implementation started with a pilot in the spring of 2022 and full execution in the fall semesters of 2022 and 2023. As of today, a total of 1,094 students from 7 different healthcare professions have completed the program. These students have engaged in structured learning activities and simulations designed to foster teamwork, communication, and collaboration skills essential for effective healthcare delivery. The facilitators have played a crucial role in guiding and facilitating these education sessions. A total of 80 facilitators were trained internally within UB, and an additional 30 facilitators were sourced from clinical practice settings, primarily from Kaleida Health with the help of Dr. Snyder. Having facilitators who work in the clinical settings can stress the importance of Team Steps and help the students to understand the value of the skills that they're learning at UB. So our training program consists of asynchronous online modules, followed by a role play session to practice the tools they learned. After role play, students then participate in simulations with scenarios situated in the outpatient, long-term care, and acute care settings. This is to show that Team Steps tools are effective and needed in all settings. Part of the Team Steps program, so this collaboration created this toolkit, but they also created measurement tools, and measuring outcomes is definitely important. There are a number of different validated tools available, including the Team Steps Teamwork Attitudes Questionnaire or the Team Performance Evaluation Tool. We have collected data through the entire program, and we have analyzed through the fall of 2022 using the Team Steps Teamwork Attitudes Questionnaire. We found that there was a significant increase in all constructs of Team Steps from baseline to post-intervention for our students. So overall has been a successful implementation of Team Steps as an interprofessional education initiative. And this signifies a commitment to enhancing patient safety and healthcare quality through the development of effective teamwork and communication skills among our future healthcare professionals. So I'm going to turn it over now to James Koza, who will introduce the first tool we're covering today from the communication domain.
All right, thank you, Kelly. Hi, everybody. My name is James Koza. I'm the UB School of Nursing Simulation Coordinator. I'm also a practicing UBMD emergency medicine nurse practitioner, primarily practicing at Buffalo General. I'm also a new member of the UB IPE leadership team. So I am happy to present this very helpful communication tool that we use in hospital. Certainly use it in the emergency room. And this tool is something that you can easily apply to your own personal and professional life. So let's get right into it. Okay, so I'm going to make a big assumption here and assume that most people on the call are aware that we have a football team in Buffalo called the Buffalo Bills. And there was a major on-field emergency that occurred last year with one of our players. Efficient communication, quick action contributed to DeMar's recovery from his cardiac arrest. And I just wanted to touch on that a bit. So I'm gonna ask for your participation here and ask you to use your imagination. Let's assume that you made the trip out to Cincinnati last year for a Bills game. You're a Bills fan in the end zone and you witnessed this on-field emergency. Now, back in my paramedic days, I used to post up in the end zone at the Ralph Wilson Stadium with an ambulance, and I wasn't always aware of all the activity that was going on in the field. So if you can picture yourself in the end zone witnessing this emergency, as a layperson, how would you report this initial incident to me? With me being unaware that what was occurred on the field, what kind of information would you want to give me? Anyone can just speak up.
That a player collapsed on the field.
Okay, very good. Important. A player collapsed in the field. Okay. Can you recall watching that game? Is there anything else that comes out that you would want to relay to me? I have no idea what happened up there.
I did, and I remember watching him after being hit, which of course they're hit all the time, just to stand up. He stood up and took one step or two steps and then just collapsed.
Mm-hmm. Thank you. Anybody else? Any other information that you'd want to let me know about?
What's his status?
Right. So important. Like, where is he at right now? What's the situation?
Probably tell you who came on the field to help him.
Okay. Yeah. So there was quite a few people that came out in the field. So he was already receiving some attention at that time during the game. So that's also important. He's already getting some sort of attention and assessment and care. Good. So keep that in mind while we discuss what SBAR is all about. So we can structure all of that great information that you gave me into a concise report. SBAR is a structured communication framework tool that can help teams share information about the condition of a patient or a team member, or even about an issue that needs to be addressed, even if you're not in healthcare, just something that needs to be addressed that other members of the team may not know about. So it stands for situation, background, assessment, and recommendation. This tool is widely used in hospital and other disciplines, and it can be used to express a concern, speak up concisely, and you can use this to frame any conversation. I've used this to frame emails regarding things that happen at work that are not medical related. And it's particularly helpful for critical situations that require a team's immediate attention, onboarding someone to a situation quickly. It may also be helpful with providers or other personnel that aren't part of the core team, like remote consultants. So thinking about this, what's the situation for Demar? What's happened? What's that one-liner that we can frame this situation with to our EMT person on the sidelines? Any thoughts?
Player was hit and collapsed.
Perfect. Player was hit and collapsed. So Buffalo Bills player collided with an opposing player, he's laying on the ground, and he collapsed. Perfect. What's our background? What's the pertinent background? Do we have any background information that we'd want to give?
If you knew his medical background, that would be helpful, but we don't as an observer. So I guess just the nature of his position and where he was hit, or if he's had any previous incident of any kind.
Was he hit by another player? I'm trying to remember. There was some impact involved, right?
Right. So there was a collision, right? I think these are all important background information. Right? There was another player involved. There was a collision. Like you said, we don't know his medical history. We know he's probably in his 20s. He's number 3. He plays safety. I don't know if that's pertinent or not, but it's background information that we can give. These are all good things. And
I have a question. I'm an anthropologist, but would demographics figure into anything? Like certain groups, there might be more prone to cardiovascular events than others, or different. I mean, I don't know. I'm just throwing that out.
Yeah, I think this would be a good place to put some of that demographic information, pertinent demographic information. At least it'll, at the very least, identify who the person is. So I think that would be appropriate for a background section there. So how about your assessment? What do you think the problem is? If you can recall watching that game, what did you think the problem was?
I think initially people were thinking it was a head injury or something. Certainly not that it was cardiac arrest, but
Yeah, we all had those conversations. Is it his neck, his back, his head? What's going on here, right?
Yeah, I didn't really think any of that because when he was first hit, he walked, right? And if you have a spine injury, usually that doesn't happen.
Sure,
you don't get up.
Okay. And so maybe more of a chest injury. He appeared to be unconscious at one point. He wasn't moving. So providing that assessment to the team. And would you have a recommendation for the EMT on the sidelines? What would be your recommendation to them?
Start CPR.
Yeah, get out on the field. He needs your help.
Remove the helmet. Get access to the chest area.
Good. Good. So this is a nice structured way of reporting an SBAR. Before we get into our practice, where everyone's going to have an opportunity to get into SBAR, I'd like to solicit the group if someone can provide me with an emergency medicine condition. I'm finishing up a shift at the ER. I need to give a patient report to a fellow provider so I can go home and have some dinner, perhaps. So there's a patient that I have that I need to give a report off of. Can someone give me an emergency medicine condition so I can give you a quick SBAR? I'll try my best. Something someone would come into the ER for.
A cervical burst fracture.
A cervical burst fracture? Okay, yeah. So we already have a diagnosis. This person's already had a CAT scan, it sounds like. Okay. Okay, so or they came in from an outpatient setting. So the situation is I have a 32-year-old male came in with a cervical burst fracture. Background is he's 32 years old. He doesn't have any medical history. He was riding his motorcycle on the 33, lost control of his bike, and suffered major trauma, multiple injuries, including a cervical burst fracture that was found on CAT scan. Our assessment is that he's alert. He is currently has a C collar on. He's been seen by neurosurgery, and he has. I would go into a neurologic exam briefly. Recommendation is to control his pain and ensure that he's admitted to the appropriate team for hospitalization and surgical intervention if need be. So something to that nature, just running through that SBAR. This is the time where we'd like for you to try. So what we're going to have you do is we're going to set you up with a breakout room with around 3 or 4 people. Upon entering the room, just introduce yourselves. Take some time to introduce yourselves. We're going to be giving you 3 different pictures. So just take time and look at one picture at a time. Each person can have an opportunity to create an SBAR report based on the picture. And feel free to embellish this interpretation of your picture. It'll add more fun. You'll have more fun with it that way. So at this point, we'll have you break out. Welcome back, everybody. I hope you at least had an opportunity to try SBAR. Those are some of the pictures that we use within our team SIPS training for all of our different disciplines. So how did that go? Would anyone like to share what their impression was of using that tool?
I don't want to dominate the discussion, but so my understanding was that SBAR was like a handoff tool, right? So you finish something and you want the next person to take from where you left, kind of pass a baton. Mm-hmm. The cases that we were given, I don't think they necessarily led to that scenario. They were more kind of a problem-solving strategy. Because there wasn't really, I think the kid, pick up the kids, that was a teamwork, right? There must be another parent somewhere so you can coordinate and call and see something. But the other one, I didn't get, I got the idea of what sort of you're supposed to do, but I didn't get the team flavor of it. I don't know, what did other people think?
Katya, I think another conceptual way that may help you is it's a way to frame any communication. Think of it as a memo. You want to send a memo to your team, a memo to your group. Mm-hmm. And that SBAR format that's succinct in as short a word as possible, right. Get the highest yield information across with clarity.
Okay,
and
got it.
That helps broaden the applicability.
Okay. Mm-hmm. Now that really, I think, is very important because when people think that, oh, there's a problem with communication, we need more communication. That's not always the case. You don't always need more information. You need the right kind of information.
One of the beauties that Dr. Ramos had added to SBAR is a little R afterwards, which is to reply back that you heard what I said. So when you do it as a 2, you can force now read it back to me and make sure you heard everything I transmitted to you.
Super.
Which pictures did you find more straightforward to use for SBAR? Or ones that were more difficult?
As I said, I like the first one. We all had the same pictures, right? So the flat tire and kid stuck in the daycare.
I like the one where she was sick and couldn't attend a meeting. There was a little bit more chance to interpret what was happening there.
How do you envision applying SBAR in your professional or personal lives? Do you envision using this in any capacity?
This is going to sound silly, but I have young adult children who call in crisis. So I'm going to put this by the phone, actually, for a couple of them.
That's great. When we run simulation here at UB School of Nursing, the SBAR acronym is right next to all the phones for the students to reference. That's a great idea. Well, thank you.
I highly recommend you consider using it for emails as well.
Oh, yeah.
It's a nice structure and framework for email communication.
Absolutely. We'd like to move on to our second of 3 activities. And I'll hand the baton over to Dr. Schneider.
Hi, everyone. I'm Ken. I'm an associate professor in neurosurgery at the University of Buffalo, vice president of physician quality for Kaleida, and co-director of health system science for the medical school. Excited to share some of the skills on leadership. As Dr. Ramos and Dr. Jacobson pointed out, almost 60% of all healthcare related errors have some form of communication failure. These tools were built in and developed to try and mitigate those factors, be able to learn from them and improve the culture of the healthcare scenario. But these apply to any workplace, family, and even for self-improvement and self-reflection. And I think we've touched on it. There are crucial conversation tools that are critical. Anytime you want effective execution of a collaborative project, these come into play. Improving culture and setting up a space of continuous learning is also when these tools are critical. And these are evidence-based, and if evidence-based proven to improve patient safety and errors in the healthcare setting. With that, I'm going to talk through 3 brief tools that we use in leadership. And one of the biggest problems is that all of the students that we teach it to say, well, who's supposed to be the leader? And this isn't a hierarchical structure. One of the keys we bring up is any one of you should be stepping up and helping walk through these roles together if no one else is doing it. Each and every person is the leader and should be capable of stepping in to lead and help one another. That's the critical aspect. And so when you walk through the exercise, again, think of it non-hierarchical, but what's key is, do you all know each other, even by name? Because if an emergency, if we begin with we'll call it a brief, it's really the introduction. It's really the setup and the expectation management. And are we all on the same page? And is there opportunity? Am I missing something? Looking over each other's back in the sense of, are we seeing all the potential complications that might occur? But let's take a moment and all get on the same page. And the vast majority of errors or problems occur because that moment doesn't occur. So let's get the team together. Let's take 1 or 2 minutes and let's get lined up for whatever we're going to execute, whether that's a plan for the day, patient care for the day, any element of project that you're working on for that day. First, most important thing, do we know each other? Do we know each other by name? Because if an emergency happens when it comes to situational awareness, being able to call each other out by name is critical to be able to help assign roles or flex and impart. Do we each understand what the role and responsibility is for us collectively around the table? Are we covering all the aspects of what need to be covered? And if not, now is our moment to brainstorm or divide and conquer. Is there too much role or responsibility on one individual? Do they have the capacity and capability to take on the task that they're taking on? And if not, now is the safe space or moment to say, I need help, or if I have questions, who do I reach out to? And so it's just kind of that brief moment of, here's the expectation management collectively of all of us. We'll lead by example. We're all available, and let's execute. Next slide. This is a ending component of the day. I'm going to put the huddle somewhere in between because it can happen at any moment. But let's imagine that the project is over, the day is over, something's completed, and now we collectively as a team are going to get back together and talk about how we did. Again, I like to teach it as, think of one great thing that happened today and one thing you'd love to work on. Even that simple element around a project or task can lead to incredible continuous improvement. But the others are, did we all work together well? Did we miss something? Did we react and flex appropriately to the situations that may have arose through the day? What could we have learned, and how do we make tomorrow's brief better so that we better execute and have an improvement or learning opportunity for the debrief at the end of next day? Very few teams do this formally. And formalization of this, even internally for yourself, can lead to incredible improvements in efficiency and learning opportunity. Next slide. The huddle is, and it can occur multiple points in the day, depends on how long the project is, depending on how you frame this, but it's just a checkpoint, a pulse check of how are we all doing? Did anyone learn anything through their project that they want to share with everyone else through the day? Is there anything that we need to better plan for? Is there any other resource allocation we need to make? Are there concerns that anyone has? Or are we moving forward with the mutual goal we've agreed to? Are we on target and are we on task? Next slide. So one of the extremely formalized ways that we have implemented this in healthcare is in the operating room. And we've done it this way because of the numbers of errors and harm events that have occurred. And one element that you want to try and pick up from your brief, or you know that the culture of safety has been implemented well, is when you're catching error events before they've ever caused harm, where you are identifying risk or opportunities for improvement before they've ever caused a problem. So the formalization of the structure is to set yourself up for something like that. We'll move beyond the sign-in part and go to the timeout. The timeout occurs when the patient is prepped, draped on the table, the team is ready, the scalpel has not been handed off, and we're about to start a surgery. There are multiple people in the room: anesthesia, nurse tech, surgical nurse scrub, residents, fellows, attending surgeon, everyone's around the room. It's a pause where everyone stops what they're doing, focuses, introduces each other to one another. We talk about exactly what the procedure is and what we're doing, the duration of what we expect it to be, the critical moments in the case that may come about, how much blood loss, how much we might need from a resource perspective. We make sure that the fire risk in the case is low, because operating room fires, unfortunately, do really occur. We make sure that the prep of the skin in the surgical area has been prepped appropriately for the appropriate time. We make sure that all the equipment is working. We make sure everything's sterilized. And then we go around the room and ask everyone, does anyone have any additional questions or concerns, or anything I might not have thought about? We then, again, have talked about blood loss. And then once everyone's ready, then the scalpel's handed off and we're able to start the case. At the end of the case, we go through a debrief. And usually at some point in the case, I will check the room, or as surgical attendings will say, is everybody doing okay? How are we doing, everyone? Anesthesia, how are we doing? How's our blood loss? Everything looks stable. It's that huddle pulse check of how are we doing? Looking at the time, is everything going well? End of the case, it's again very formal. What did we do procedure-wise? How did was the wound infected or non-infected? Our counts are perfect or appropriate, or is something missing? And what do we do about it to find it instead of find it a year later inside the patient? What are our surgical specimens named, and where do they actually need to be sent? Where's the patient going to go post-operatively, and what are the care parameters around that? When do we need calls? And is everyone comfortable with the plan? So again, that is a example of a very formalized version of that brief, debrief, and huddle, but we do it every single day for every single surgical case. And anytime there's an error event or a missed opportunity, we go back to our policy, procedure, and process and say, how can we ensure it doesn't happen again to another patient? And we use this framework, this foundation to build from. Next slide, please. There was an example. We don't need to necessarily show the video, but it was a video of kind of a good checkpoint or huddle. I think you can envision it in your mind, but maybe for the next minute, can anyone think of an opportunity or scenario in your current work environment where you might be able to formalize or implement some of these brief huddle or debrief tools? Maybe we can go to the slide before this. Actually, I think the brief is the most important because it sets up everything else that follows.
We do have videos embedded in each slide if you want, if we'd like to see one or two of these videos. If you'd like.
They're each about 30 seconds long. Maybe if we were going to do one, let's just do the brief.
The brief, yeah.
Okay. She currently only has intermittent late decelerations, and these have improved with her position changes and supplemental oxygen. We'll monitor her until she's fully dilated and allow her to push. If there's any evidence of fetal distress or persistent late decelerations, we should be prepared to go to C-section.
I've alerted the OR to be prepared in case we need to use it.
Great. I'll discuss this plan with Mrs. Keys when we're done here. What are her vitals right now?
Normal, just checked 15 minutes ago.
She's had no late deceleration since you recall. Let's continue to monitor her. I need to know when she's complete and pushing so we can keep a close eye on her second stage. Any questions?
Thank you. Thanks for that. Good enough. I think we get the idea. Comments from anyone? Thoughts on how we might be able to implement some of this in your current work environments, or examples of when you use it?
I think this is well suited for like a grant submission when you're working on something and you meet with your team. I don't know how often you need to meet, every week, and you say, okay, how's your test going? How's your test going? You having any issue? Do we need to reallocate? Something like that. But again, it has to be a long-term project, right? It's not something once and done. It's roles are assigned and people don't necessarily observe each other working. But that would
but
be
also
great.
the debrief with the grant. What,
Yeah.
Well, what should we do differently going forward?
Yeah,
That's
and
the whole thing.
afterward, yeah.
Yeah, as a grant, as applicable to a grant submission, large grant. Yeah.
Yeah.
Katya, you bring up a wonderful thing in the chat, and I think it comes back to culture. There are ways to bring up when an expectation management was not met by a team member without making that team member feel unvalued or devalued. And I think there's an element of crucial conversation that would happen either after the huddle or prior to the debrief that helped give some feedback to that individual if it was noticed then, and or as a team, because all of us, I think about it like our M&Ms. Be very careful when you're critical of someone else, because next week it's your case up there and you're standing in front of the group. And so I think we as leaders or as team members should lead by, it could have been me, and probably I didn't communicate well, but we noticed this element lacking in the case. What could we all do better, right? And those often help that individual recognize that they dropped the ball or could do more, and often they then speak more. So I think there's some tricks and tools to help not make it that we're berating somebody. But I think that consent, that ability to be in front of your others when you said, I'm going to do something, and say it didn't work or I didn't do it, is how you continually improve as a team. And it's an important element. I think if you back away from those crucial conversations, then I don't think you as a team succeed. And it's very hard to do, but the more you do it, the easier and better it gets.
Right. Right. So if it works, you get better. If it doesn't work, then it's a blowout, right?
Yeah, right.
Well, creating a safe environment, really important, so that people realize that they can speak up, that nobody's there to criticize and blame them for individuals, but to find out why the situation didn't go well and how it could be improved upon next time. But that safe and psychological safety is really important too.
And Dr. Jacobson brings up another great point. We should first think to systemness. we should first think to how did we set up that we allowed the individual to fail or not work? What other things could the system or could we have put into place to ensure that that doesn't occur again? And that starting with systems, starting with process failure usually helps navigate those personal issues also. Now we'll hand over to Dr. Ramos, unless there's any other final comments to mutual support domain.
I think this is a great bridge to the mutual support domain, because when I think of mutual support, I think of conflict resolution. And certainly if a debrief is handled in an incorrect way, it could lead to some conflict. So before I talk about the actual tool, I want to poll the audience. So what I would like to know is, and we're going to put up a poll, how would you rate your own comfort level with conflict resolution? So how confident are you in your conflict resolution skills? So I think this is pretty telling, right? I mean, the majority of people are only somewhat confident, right? So conflict resolution is not something that it's not an innate skill. It's something that you definitely have to develop. But it is really key to have conflict resolution tools in high functioning teams. So think about the impact it could have on patient safety if maybe I have an interaction with someone that's not good because I'm questioning something that they're doing for patient safety reasons. I don't address it with them. The next time I see it again, I don't say anything, right? Because I'm afraid. So we really need to have tools for addressing conflict respectfully. So I think we'll move on to the next slide now. I'm actually going to start with, well, DESK is the tool that we're going to talk about for mutual support. And this is one where you would bring a person out privately to talk to them. But I'm actually going to start with a video that describes it a little bit, and then we'll talk more about it.
Lindsay has developed a habit of gossiping about the doctors and other staff with coworkers. It's bothering her coworker Karina, especially since patients can hear. She wants to bring it up with Lindsay, but she wants to get it right. Hey, Lindsay, can we talk? Is now a good time? Yeah, what's up? So I've been thinking about this a lot, and I felt like I had to say something. I noticed that you sometimes vent about the doctors when we're at the front desk. So what? It's healthy to vent. That's what I always say. I'm just worried about the kind of environment that creates. I know it feels good to gossip about work, but it would be best if that happens in the break room or somewhere out of earshot of the patients. When patients hear you say something about any of us, it may make them feel less confident about the staff and the care they're getting here. You know what I mean? Yeah, I guess if I were a patient, I wouldn't want to hear that stuff about my doctor or the staff. Let's go over what Karina did well. She was prepared for the conversation and pulled Lindsay aside in private. Karina used I statements that make suggestions about how things could change. She focused the conversation on having a more enjoyable workplace while also keeping the best interests of the patients in mind.
So that was a really brief look at DESK, but it was a great example. And this, again, is a tool that would be good to use in any situation, in a work setting, in healthcare setting, at home. It's really a respectful way to address conflict, and remembering these describe, express, suggest, and consequences. So we're going to move on to another video that may not have been so successful.
Marcus has noticed that Nate is consistently late to their weekly staff meetings. Marcus has covered for him almost every time, and he feels like Nate isn't pulling his weight. This is starting to make Marcus feel stressed, angry, and resentful. He resolves to bring it up with Nate.
Hey, can I talk to you about something?
What's going on?
I've noticed that you've been late for staff meeting for a few weeks in a row now. When you're not there to give your update, that falls on me, and it makes me kind of stressed out. I don't know. Maybe in the future you could set an alarm so you can get there on time? Or, I guess the main thing I'm trying to say is, you're not really pulling your weight, And when I have to cover for you in meetings all the time, it makes me look bad.
Wait, what's that supposed to mean?
Let's rewind and try this again.
Hey, can I talk to you about something?
Okay, so before we look at an improved scenario there, what are some things that you would pick out that they could change to make this a better situation? Anything you noticed?
It could have been done privately.
Yes, privately. I loved the the person with the vacuum cleaner, right? What else?
He used a you statement saying, "You made me look bad."
Mm-hmm. Yep. And how could he have said that with an I statement? Can you turn it around?
He kind of said that early. He said, that makes me anxious.
Mm-hmm.
So it's his feelings, right?
Right.
Really.
Right. It's more about how it made him feel versus how the other person did it. Exactly. And I think when basically you're just not pulling your weight. I don't find that to be very respectful communication. So we're going to watch this again using the desk.
What's going on?
When using de-ask, the focus should be on improving the situation, not on placing blame. That way, the situation doesn't fester and get worse over time. It's important to keep things calm, prepare ahead of time, and ensure it's the appropriate time and space to have the discussion.
And so what I would highlight about desk is that it's something, there are different conflict resolution tools. Desk is specifically for something that you would address later. So it's something that you would, after the fact, pull the person aside and talk about so it doesn't happen again, so they understand what was going on. There are other tools that you would use if you were experiencing conflict that was an immediate patient safety concern. But desk is really the one that's most valuable for us to use every day, anywhere. So it's a good one to cover. And I just wanted to add too, when TeamSteps was developed, they brought together experts in healthcare and education, but also the aviation industry. And a lot of TeamSteps is built from crew resource management. And when you think about when you go to fly on a plane, all the checklists that are gone through before you're able to get up in the air, it's just important for us to do that in healthcare before we do a surgery or something like that. And that's what TeamSteps is. It's a safety language. So I am actually going to, I think we're about ready to wrap up. So I'm going to hand it back over to Dr. Gambacorta.
Thank you very much. And I'd like to thank everyone for taking some time to attend. Our hope as the presenters is that you have a better understanding of the importance of communication, teamwork, and really and how that can affect outcomes. And I think too, one of the things that was done exceptionally well was how this can be utilized in almost in everyday life situations, and not necessarily just in the field of healthcare or delivering care to a patient respectively. There's a lot of tools and things that we discussed tonight that can really help as you navigate certain things. And obviously the things that Kelly just showed with desk, you could see how that could really help in resolving things around the office, possibly around the home. I think Linda mentioned something with children and SBAR and things like that. So I think these are all real positive things that you can take away from this and realize too how important obviously communication and teamwork is to everyday life. But think of how much more important that is when you're dealing with direct patient care, especially when you're dealing with a crisis situation, as we talked about with Damar Hamlin. So we'd be happy to entertain any questions from the group that you may have. And again, thank you to all the presenters. And thank you for the opportunity tonight for the Office of Interprofessional Education to present to this group. We appreciate that.
We do have a question in the chat about liking debriefing. but being told that negative feedback must be in private. So
can't Dr. Snyder already addressed that?
So what do you do in that situation though? So it's addressed that debriefing is not always positive. But what do you do in that situation if we're not talking about the desk situation, but the situation prior to that?
You know, I looked at that question based on clinical care, right? So I didn't look at that as, say, conflict resolution in the office or something maybe in a different setting. I looked at it strictly from a clinical care standpoint. And obviously things do go wrong in the delivery of clinical care sometimes. So that's when I looked at that question, I said to myself, well, yeah, I've had debriefing sessions with students and residents in our clinics that have not been the most pleasant, because obviously you want to point out critical mistakes that may have been made. And those conversations sometimes are uncomfortable. And in some cases like that, when you're dealing with a team of residents or students who are providing care to a patient, you have to have those conversations not, with the whole group. Now, obviously it's not a he said, she said situation, but when you're talking about a negative outcome, those conversations, as I mentioned, are uncomfortable, and they have to be had so that you look to prevent the negative outcome from happening again, right? So those are some of the cases that I felt when I answered that question in the chat that I felt would be something that would be unfortunately negative. If you're looking at where you can pull somebody away, right? I think you can certainly debrief privately, as Kelly showed in some of those scenarios. And I guess too, all of us as faculty in one time or another who have worked with students have had to debrief in private, but in some cases you have to debrief as part of a group because that group was assigned the clinical care of a specific patient.
Thank you.
That's the angle I
want to debrief as a group, just so that the whole group learns. But I think it's, again, as Joe was trying to say, was saying as well, that you have to set up a culture of not blaming, and you're not looking for scapegoats. You're not looking to find a person to tell them they did something wrong. There's something called debriefing with good judgment, which is where you basically say, I noticed this, and you give a very specific example of what happened. Could somebody explain what was going on? Well, sometimes it's a frame of reference of an individual there. They were looking at it a different way. So there's this backstory you just have no idea about. I noticed during that code that we weren't able to get the IVs in soon enough. What was going on in that situation that led to that problem so we could fix it next time? Oh, well, I went to 3 different drawers and the equipment wasn't there, and I finally had to find it. Well, by the time I came back, it took a while. Whatever the story is, the system problem is we got to stock the drawers better, or we got to make sure that we've changed that up for next time. So trying to find out where errors occur without blaming individuals, I think, is really important in giving good feedback and improving team performance.
I like that you said we in that situation, because that allows everyone to realize that it could happen to anyone at any time. Mm-hmm. And that's really important. It's how you do the debriefing, whether it's positive or negative. That's really important because we learn from our mistakes. And if you learn from your mistake, you're less likely for it to happen again. Thank you.
Sure.
I suppose that's all true, but it seems to me kind of inevitable that given the specialization of people in any of these teams, that you can say we did or this didn't go exactly as planned, but there was probably an individual assigned to that task. And so even if you don't name the individual, there is an implication that somebody didn't do what they were supposed to do. It just doesn't seem like you can do a debrief without at least implicating somebody in the failure.
I think accountability is critical, and especially in our role and task. And there's no way to perform our tasks without accountability to ourselves, to our patients, and to each other. We begin with system, but it doesn't mean you let someone hurt a patient 3 times in a row. That individual may have a role and purpose in life. It just may not be patient care. And one of the harder things that we do is have to redirect that individual's talents to maximize them and be as educators of providers that have an ability to unfortunately cause major harm to an individual, it's our role and responsibility to train them appropriately, ensure that they're learning. It doesn't mean zero event or zero error. It means continuous learning and continuous improvement. We begin with the system, but accountability is there.
And you know, even no matter what it is, like medication error or whatever, there's obviously somebody administered the medicine. But however, the question is, I noticed, or the problem is that the wrong medication was administered. What led to that problem? You know, nobody wants to do harm. Nobody wants to be evil and hurt people. So maybe maybe it was, you know, the order wasn't very clear. Maybe they misheard the order because it wasn't, wasn't clear enough to the individual who did it. Maybe they were handed the wrong thing. So trying to get at the actual source of the problem, I think, is important, and, you know, treating it as a system problem. And then figuring out, hopefully that person, as it comes to light, that person's going to realize how they could have done something better, or, you know, or averted the problem.
We actually have a measure as a system of how we're doing. What happens is that the harm events or minor events reduce and the near misses elevate. It means that people bring their own errors or concerns forward, the ones that never caused patient harm. It means that the individual in the team feels comfortable enough to say, you know what, this messed up, or I messed up. Thank God it didn't hurt the patient. I want you all aware this occurred. Those are called near miss events. We measure those every month compared to serious safety events and precursor events. And it's that shift in culture of near misses, continuous. If we don't see enough of them every month, it means people aren't comfortable speaking up. But when you have individuals bringing their own errors forward that have never caused harm to a patient, you're really on the right track culture-wise for continuous improvement.